Graduates and residents. Number of cases I am giving is 20. Actually, this is a spot diagnosis, but then you can take a minute or two in order to answer properly. Rules of quiz, no description. You don't have to say this is a PAV of the chest or this is an angiogram and these are the major findings, these are the minor findings, and then this is the differential diagnosis. Just mention only one diagnosis because they're so typical. We can make a diagnosis and write your name and hospital so that we can evaluate your papers. This is a self-evaluation quiz. That is, you go through these cases and write down the proper answers. Please spend few minutes for each case. Write down your diagnosis and evaluate yourself, comparing your answers with the correct answers mentioned at the end of the quiz. There are all 20 or 21 correct answers. But try to be honest. Don't go through the last and then cook up the answers. After you have checked your answers, proceed further for the discussion of each case. Then I will discuss. This 22-year-old male complains of dysuria. There's no high fever, but just dysuria, not even renal colic. The one on your left side is the plain film. Of course, it's a coned down plain film of the right kidney. What do you see? And then the next two pictures are IVPs. Again, coned down on the right side. So, having observed, you please write your correct answer. Plain film, and then IVP, and then delayed IVP, just a little delayed IVP. You see the findings and write your diagnosis. This is a 37-year-old female with history of backache for 2 months. I believe females are divided into two categories, one with backaches, one without backaches. And anyway, particularly CT examination done at the pelvis level. There are two cuts. You see the bladder and you see the mass and you write your diagnosis. Observe carefully, but don't write all the observations. Just give a final diagnosis. 35-year-old male complains of pain in the left leg. Has got repeated pains in the left leg. And of course, AP I have not given because it's not contributory. Only lateral I have given, so that major findings are seen there and you write your diagnosis. 34-year-old female with abdominal pain. And then one on your left side is the plain film without contrast. Next, with oral contrast, they have taken CT, two sections. There is no IV contrast, just oral contrast, you could see. Observe the findings and make an appropriate diagnosis. 42-year-old male with painful swelling of the foot. Only coned down of the tarso-metatarsal joints or portion of the metatarsals is given so that you can observe the findings, major findings, and come to a reasonable diagnosis. This case number 6, is a 55-year-old with symptoms of paraparesis and lower limbs. In the lower limb, there is some paraparesis. One on your left side is the PAV of the chest, obvious. And you see the findings, if there are any. And then because of the paraparesis, they have done a myelogram. The one on your right, AP, and lateral views of the myelogram. Case number 7 is a 27-year-old male with sudden unconsciousness. Suddenly he got unconscious and the relatives brought him to the hospital and they have done a CT and these are the findings. Case number 8 is a little tough case. 14-year-old male with chronic cough and breathlessness. A teenager, but chronic cough and breathlessness. And you see the CT rendering of the three-dimensional rendering of the chest and the findings are obvious. Case number 9, a 42-year-old male with chronic pain in the right lower quadrant. He was not, he didn't have any appendectomy or anything. Chronic pain, lower quadrant, has undergone a GA series and this coned down view of the right lower quadrant with pressure. That ring is the balloon pressure so that you can see the spot film. Case number 10 is a 35-year-old female with hypertension. high blood pressure. And they have done an IVP, plain film, ultrasound, and this is the angiogram. I have given just only the cone down view of the right side. Part of the tortuous aorta is seen, but right renal artery is well seen. Right diagnosis. Case number 11, just a 3-year-old boy. He is not faring well. Mother brought him and said somehow he is not eating properly, not gaining weight, he is not quite active. And these are the radiographs of both hands. A 32-year-old male with the swelling of both hands. This is case number 12. Irregular swellings of both hands, and both hands radiographs are taken, and these are the films. You please write the diagnosis. These are all classical films. So, case number 13, 21-year-old male with swelling of the left little finger, wrong swelling, and you see the radiographs. Case number 14, a 30-year-old male with history of convulsions. For months together, he had some convulsions, and plain film of the skull was taken as a routine, nothing was found. Then they took the CT. Obvious findings are there and come to a conclusion. Case number 15 is an 18-year-old male with dysuria, and IVP was done, and this is not a direct cystogram, it is the indirect cystogram. IVP delayed film just for the bladder, and you see the findings. A 32-year-old male with painful swelling of the right neck, oblique view on your left and AP view on your right. The findings are obvious. A little deviation of the trachea to the left side is noted, that's all. Case number 17, a 32-year-old female with irregular periods. 32 irregular periods. And this is the plain film of the pelvis. No contrast was given. Plain film and write a diagnosis. Case number 18, a 21-year-old man with painful right knee. On the left side is your lateral view of the knee, cone view, just lower end of the femur, proximal end of the tibia and patella, and that's the cone view, and this is a regular view on your right side. You see the major findings so that the cone view can reveal what the findings are. Write the diagnosis. Case number 19, a 14-year-old male with painful swelling of little finger. That's obvious. There's some abnormality in the little bones of the little finger, and write your diagnosis. Case number 20, a little tough case, but I'm sure these findings are classical and you can write the proper diagnosis. A 27-year-old male with pain in the heel, and obvious findings are there. In the lateral view of the ankle and part of the foot, you see the calcaneum and the lesion posterior. Write your diagnosis. This is a bonus case. All the cases of 20 from 1 to 20 are routine cases, in the sense a good radiologist, a good radiological student and a resident can make a full diagnosis of all the cases and get 100%. But this is a bonus case. It's not usual. Once in a lifetime probably you can say. And note the findings. Some anatomical abnormalities there. Write the diagnosis. I have given you a clue about the anatomical abnormality. Write the diagnosis. Now we will go through the correct answers. First case, I showed you plain film and IV urography. There is a calcific density in the right kidney, in the lower calyx. But then that calcific density is not circular. It is not very dense. It has got a horizontal margin. And IVP also consistently, it has got a horizontal margin in calcium. This is classical of a milk of calcium. You have heard of milk of calcium bile in the gallbladder, where the bile salts precipitate, and in the erect posture they form a line. This is not an erect posture, but still on lying down also you can get a layer of the normal urine and heavy calcium at the bottom. This is called the milk of calcium urine. Often there is an infundibulous stenosis. either congenital or acquired. And so one calyx dilates and urine goes through, collects there, stasis, maybe infection, but here there are no signs of infection. Stasis, calcium deposit, slowly, minute particles of calcium oxalate crystals. Generally the urinary calculi most of the time are calcium carbonate and calcium oxalate. Of course, rarely you can get cysteine, ammonium oxalate, etc. Urate crystals also, but they are not radiopaque. So I'm sure all of you got right. Then second, a female with a pelvis and a mass. If you see the mass, it is dumbbell shaped. The term dumbbell shaped indicates some neurological tumor. What is the neurogenic tumor? It is huge, has got areas of necrosis, there is no calcification, there may be some erosion of the sacroiliac notch. This is a malignant lesion. What type of malignant lesion is it? It's fibrosarcoma, it's malignant fibrous histiocytoma, leiomyosarcoma, but since of the dumbbell shape, you have to think of a neurofibrosarcoma. About 10% of the benign neurofibromas or schwannomas get into malignant and is one of those, neurofibrosarcoma. The third, only the lateral view is given because AP view you don't see much. What is the lateral view of the leg? What do you see? Multiple parallel lucencies. They are less than 1 centimeter. They are lucencies, parallel. What are they? These are, clinically they call them shin splints. A person who is jogging, who is running, who is jumping can get stress fractures. Stress fractures are nothing but repeated rhythmic of trauma, and these are micro fractures. Why is there lucency? See, repeated trauma, because he has been running or jogging, repeated trauma produces lack of mineralization. There is no time for mineralization of that osteoid. Actually, the lucencies contain osteoid. And these are microfractures too. Reparative microfractures, osteoid is formed, but there is no time for deposition of mineral. That's why there is no sclerosis. But in chronic stress fractures, repeated stress fractures, you get a lot of callus, sclerosis. So much so, the lucent line is not seen at all. So this should be easier. This may occur in any bone that is stressful. Calcaneum we have seen, femur we have seen, proximal end of the tibia, and in fact they have described in the ribs also, stress fractures. And they should not be mistaken for osteoid seams that you see in osteomalacia or rickets. Because if you look at the bones, there is no osteoporosis or osteomalacia. These are just normal bones. The cortex is normal, the spongy bone is normal, endosteum is normal, there is no periosteal reaction, but these translucent zones, typical of stress fractures. Then, case number 4, you are given a plain film, nothing specific, gas shadows here and there, no evidence of obstruction, either mechanical obstruction or paraticalious. But then if you look at the CTs with contrast, oral contrast, you see small bowel loops located as if in a sac in the left upper quadrant. Typical. Loculated and groups of small bowel, and this is what is called paraduodenal hernia. There is a space, but there are several paraduodenal fossa, and on the left side this is common, and the small bowel is attracted to it. With it, mesenteric vessels also go through and forms a pseudo sac, and this may give rise to symptoms, abdominal pain, occasionally colic. Sometimes these are spontaneously reducible, but this big hernia generally doesn't get reduced. This is a typical of paraduodenal hernia. This is below the ligament of Treitz and beyond the fourth portion of the duodenum, above the pancreas, either the body or tail. This typical location. And this is common. There are several paraduodenal hernias on the right side also it may occur, small, but this is 80% of the time This is typical of paraduodenal hernia on the left side. Case number 5, actinomycosis. You have seen the foot and then only cone down of the foot. What are the major findings? First of all, we have to think of the findings. The tarsals and metatarsals have multiple rounded lucencies. But then those rounded lucencies have got sclerotic margins. Periosteal reaction is there, irregular. And in a group of joints and bones also, not only just joint disease, but bones also. Such a finding is classical of Madura foot. You heard of Madurai, South India, a holy place where the Madura Meenakshi temple is there. In 1896, one of the British medical officers is posted there and has seen a number of males particularly, and including the females also, coming with a swollen foot. He used to call them foot tumor and amputated. Finally, histological diagnosis is fungal infection. Commonest is actinomycosis, mucormycosis, and various types of mycosis, fungal infections can be seen from the discharge. Typically, classically, clinically, you can find a swollen, indurated foot with the discoloration, multiple sinuses discharging serosanguinous type of pus. And then if you look at the granules, from the granules alone, are they black granules, are they yellow granules, are they white granules? From granules alone, the microbiologist or clinician can tell what type of mycosis it is, what type of fungal infection it is. Since most of these people work in the farms with bare feet, any prick, any small wound can be infected, superimposed infection by fungal, because soil contains of multiple fungal organisms. And then these amputated specimens are there, exhibited in the Madras Medical College Museum also. Later on, with amphotericin, now we are preventing, or we are trying to prevent such ugly type of advanced Madura foot. It can be cured today. And today, with the introduction of at least footwear in the farmers, the incidence is much less.